I have worked as a statistician most of my life. Basic statistics is a requirement for measuring improvement. Consider the following. If I had a nickel for every time I saw the term evidence-based regarding addiction treatment, I would be rich. What qualifies for evidence-based? If a study shows a treatment works better than chance, is that evidence-based? If I could get people to stand on their head 3 times per day to help the flow of neurotransmitters, they would do better than no treatment. Research articles often conclude that something real has taken place because the chance of this happening is less than 5% or less than 1%. These values are highly dependent on the size of the samples, plus research is seldom done by unbiased people. Being better than chance is only the beginning for justifying a treatment. If the chance of a cocaine user improving on his own in 6 months is 20%, and I could double his chances of success to 40%, would this be worth spending $30,000 worth of treatment? I worked in a mental hospital with schizophrenics. The symptoms of schizophrenia, according to the Mayo Clinic, are as follows. My point is that measuring improvement in a schizophrenic is difficult. The beauty of dealing with addiction is that the gold standard for improvement is going a year after treatment without a relapse. Every study of addiction treatment should include this statistic for persons who spend at least 24 hours in treatment. I realize that relapse is common, and you can show the relapse rates for those who complete the program versus those who didn't. I encourage adding additional measurements to the gold standard, as well as breaking down the percents by sex, age, education, employment, and marital status. I would not compare the relapse rates of heroin addicts to cocaine addicts, let alone compare the relapse rates of drug addicts to people with hypertension or asthma. If your treatment sample is mostly middle-aged men, do not conclude this treatment works for everybody. Almost every study should say something about individual differences. Personality can be measured by the Big Five, the Myers-Briggs, the Minnesota Multiphasic Personality Inventory, and several others. Research should also include something about the history of the patient, including first use, peers, home environment, academic achievement, employment, and hobbies. Also something about biology and genetics, drug use by parents and relatives, other illnesses, including co-occurring diagnoses. In the future, your genome will be important. The Substance Abuse and Mental Health Services Administration collects data on drug use and overdoses yearly. I cannot find any data that shows our present treatment for addiction is more successful now than 20 or 40 years ago. In 1975, I sent out a 57-item questionnaire to a significant other of someone who was in treatment for addiction. According to those who responded, 88% said the patient had improved in 6 months. To measure the effectiveness of addiction treatment today, I would pick a random sample of persons treated for addiction 1 year ago. I would send out 2 persons to do the interviews at their homes using a standard form like the following. Thank you for your time.